which I'm going to hand over to introduce our first speaker.
Thanks, Suman. So yes, really our first speaker needs no introduction at all. It's Professor Martin Marshall. Brilliant, Martin. Great to see your webcam is working and we've got tech in order. So yes, Professor Martin Marshall, if you don't know who he is, then this is absolutely the conference for you to be at, because you should know who Professor Marshall is. He's the chair of the RCGP. He's doing a brilliant job. I'm sure he didn't sign up to be chair during the COVID pandemic, but he's doing a great job supporting trainees as well as GPs and making sure that the college is listening to what we have to say. Alongside that, it's also great as a UCL alumni to see that he's Professor of Healthcare Improvement at UCL, and as you can see, he has many feathers to his hat. So I won't delay it any further because I'm sure lots of you are looking forward to what Martin has to say. So Martin, I'll hand it over to you. But before I do, can we just launch one last poll, which I think will be something that would be of interest to you. So could I please ask everyone to click either yes or no. Do you feel that you have made the most of your RCGP AIT membership as a GP trainee? Right, okay, that's interesting. So 85% of you feel that you're not making the most of your AIT membership and 15% feel that you are. That is an interesting talking point that maybe we can discuss with Martin as we move forward. So thank you ever so much, Martin. It's a real pleasure to have you join us this morning. I'll hand over the stage to you now.
Man, thank you so much for the invitation to join you. It's a real pleasure. And yeah, and that was an interesting response to that poll, wasn't it? I think that might be something we want to talk about. How can the college be most useful to you in developing your careers? It's great to see such a wide range of people joining the webinar this morning, pre-GP and across GP training. It's a challenging and exciting time to become a GP, it seems to me, and that's, I guess, something that we're going to be talking about. We've got 45 minutes together. I'm planning to give a presentation for about 20 minutes and then open up for Q&A and discussion. You may or may not be surprised to hear that in my presentation, I'm not going to talk about COVID. I'm not going to talk about the exam. I'm not going to talk about workload. I'm not going to talk about anything that's currently preoccupying us in March 2021. So I'm very happy to take questions on any of those issues a little bit later. But to start, what I want to do is talk about what I see as the enduring essence of our specialties, something that has and will always lie at the heart of what we do as GPs, and that's the trusting relationship between patients and their general practitioner. I guess we've all got stories about how the relationships that we build with our patients at any stage of our career are important to our effectiveness as clinicians. So let me give you some examples. Just the other day, a patient who I knew very well, who seemed to trust me, we had a good relationship, presented with a viral sore throat, asking whether they needed antibiotics. I was able to provide reassurance for them in probably less than a minute, freeing up time to deal with the other two problems that they brought to the consultation. Later in the same day, I saw someone who I'd not previously met with exactly the same presenting problem. He started by complaining that he always needed to argue with his GP in order to get antibiotics. We spent 7 minutes discussing the issues. He didn't trust my explanation about why antibiotics weren't necessary. I didn't prescribe anything, and the patient left dissatisfied. Or how about the story of Mohammed, who's a 35-year-old immigrant from Iran who is obese. He's got poorly controlled type 2 diabetes, who I've been looking after for about 6 or 7 years now. I've been looking after him for more than a year, probably, before he opened up to me about the reasons for his health problems. I learned that he and his family lived in a grossly overcrowded apartment with no kitchen. He used to eat all of his meals in one of East London's many fried chicken shops. Mohammed found the food enjoyable, cheap and filling, and he didn't initially show much inclination to change his lifestyle. But over the following 2 to 3 years, probably, I worked with other members of our team and with social workers to change his life. We managed to get him rehoused. We managed to get him to join a job club, and he got a part-time job. He started exercising in the local gym, which happens to be the Olympic facilities for us. I work as a GP in East London. I managed to get him and his wife to attend a cooking course where he learned how to cook the vegetables in the markets in East London. He confided to me that he wouldn't have done any of these things if I hadn't suggested he might benefit, if he hadn't trusted me, and if I hadn't supported him through what was quite a long process. There have been ups and downs along the way, of course, and I'm not claiming any miracles, but 6 years down the line, he's in a much better place than he was when we started. Some years ago, in a challenging editorial, Trish Greenhow, a wonderful GP academic in Oxford, asked readers to think about their experience as a patient seeing their own GP. Did you like her, she asks? Did she welcome you? Did she listen to you and empathise with you? Did she remember what you previously told her? Did she show interest in you and your family? Did she follow up on previous conversations? Did it feel like she's focused on your agenda rather than hers? Did she seem to have your best interests at heart? Trish said that if the answer to most or all of these questions is yes, then you've got a GP who's attempting to build a relationship with you because she believes that that will make her a more effective clinician. As GPs, we've long recognised the power of the so-called therapeutic relationship, but it seems to me that we haven't always been sufficiently explicit about just how important it is. Please excuse me if I get all rhetorical, but it feels to me like the relationship between a patient and their GP is as important as a scalpel is to a surgeon. If relationships were a drug, NICE would have to mandate their use. But relationships and the way in which we build and utilise them aren't drugs, so we tend to keep quiet about them. As a consequence, there are many people who simply don't understand how important relationships are. And this matters because many of the pressures that we're experiencing in general practice and have experienced over the last decade or more have led to what we do becoming increasingly transactional. And by that term, I mean focused on work that's narrow in scope and time limited, rather than relational in nature. Of course, some of the issues which patients bring to their GP are reasonably transactional in nature. Uncomplicated chest infections, blood pressure checks, and of course the COVID vaccination programme, though even these activities can provide important opportunities to build personal relationships. It's difficult to identify exactly how much of our work can reasonably be classified as transactional because it depends to an extent on the individual doctor's inclination and practical ability to look beyond the presenting problem. But fundamentally, general practice is a medical specialty which defines itself in person-centred and relationship-focused terms. While some practices continue to deliver highly personalised care by maintaining personal lists, and others are exploring new ways to delivering personal care, for example, using microteams, most practices are just struggling to enact what they were trained to do, and something that we all believe to be important. And that's why the college has long asserted that what we used to call pastoral care in the old days is core to the values of general practice. And that's why over many years, we've talked about related concepts like continuity and the therapeutic relationship and empathy and person-centered care. I believe that the dilution or loss of the relational element of general practice would damage the quality of patient care and the efficiency of the NHS and the specialty of general practice. And that's why it's become a priority under my leadership as chair for our college. So let's step back a bit. We're scientists, we're trained as scientists, we're committed to using the best available research evidence. So what's the evidence that relationships matter? Relationship-based care is a term which encompasses a range of overlapping concepts, some of which have long established theoretical and empirical basis supporting them. Most usually, these include the concepts of things that I've just discussed: continuity of care, the therapeutic relationship, empathy, person-centered care. Research in all of these areas, most of which is observational or case study based, so not the most robust of designs, suggests that relationships are important. And the findings seem to be consistent over time and in different health systems as well. We know that continuity is strongly associated with increased patient satisfaction and experience, increased compliance with medical advice, better health outcomes, and lower mortality rates, even lower mortality rates. We know that some patients value continuity more than others, and this varies according to the reasons they're seeking healthcare. We also know that continuity leads to lower costs, lower use of emergency departments, reduced likelihood of being admitted to hospital, and higher GP job satisfaction. And we know that there's several instruments for routinely measuring continuity in practice. We know from qualitative studies that the key components of the therapeutic relationship include trust, a belief that a person's word and actions are credible and can be relied upon, as well as commitment and honesty. And we know that the ability to demonstrate empathy is a core component of the therapeutic relationship, and that demonstrating empathy is associated with higher patient satisfaction, better adherence, reduced anxiety, better enablement, and improved outcomes. The evidence tells us that patients want to know that their clinicians are keen to engage emotionally. They look for clues to reassure themselves of their clinician's desire to care. And we know that there's a robust neurobiological basis for empathy, with distinct parts of the brain firing up when empathy is exhibited or perceived. So there's lots of established evidence that relationships seem to matter. But I guess the question is, how relevant is this evidence in the context in which we're currently operating? What is the impact of remote consulting on relationship-based care, something that we're all doing most of the time now? This is an issue that's particularly pertinent to us as we explore the most appropriate balance in the post-COVID era between face-to-face and remote consultations. Some of the research about the use of telephones has been around for decades, but new evidence about all forms of digital consultation is developing rapidly. The established literature tells us that telephone consultations tend to be shorter, cover fewer problems, are characterized by less data gathering, less advice, less rapport building, and are perceived to be less safe than face-to-face ones. We also know that relationship building can be stronger by video than phone, possibly because as doctors, we tend to give more attention by video, and because of the benefits of seeing facial expressions. And interestingly, I love this study, an RCT carried out in Hong Kong recently suggested that video consultations are more effective than face-to-face ones carried out when both parties are wearing masks. So there's something about seeing the face which is rather relevant at the moment. I think there's a number of important questions that we as a college and across general practice need to address if we're to take relationship-based medicine forward in a way that benefits both patients and clinicians. So before opening up for questions about this or about other issues, I'm going to focus on 6 of those questions. The first is, are relationships sufficiently important that they should be actively promoted and designed into future models of general practice, because general practice is changing rapidly? I think that the benefits that I've outlined are sufficiently important to suggest that they should be, and that new policies impacting on general practice should be risk assessed to understand their impact on relationships. Our challenge is to determine when relationships add sufficient value to ensure that their benefits are utilised, and when they don't. For example, when a patient should be looked after by booked into with one doctor they know, or when they could be booked with any clinician. We know that some people value continuity more than others, particularly older people, for example, and some health problems or conditions benefit from relationships more than others. For example, people with multiple morbidities and some of those with mental health problems. One key practical step to increasing the length of non-triage GP consultations. The traditional 10-minute consultation is a major impediment to relationship-based care, increasingly so as the complexity of the problems presented to us increases. So this requires both a reduction in workload and different ways of working, both things that we are working on hard as a college. My second question is whether relationship-based care can be delivered in the absence of continuity of care. The evidence is clear that knowing patients over time is an important element of relationship-based care, but my question is, should it be a defining one? A growing number of doctors like me, and probably many of you, work part-time. Many work as locums, and many are unable to work in a single practice for a long period of time. I started life as a partner in Devon, expecting to be there all of my career, but my academic career took me to Mosside in Manchester and now to East London. I've moved around. I'm not able to look after patients for 35 or 40 years in the way that many of our predecessors did. Whilst continuity of care should be encouraged, if it's framed as essential, then to my mind, there's a risk that a large proportion of the workforce, like you and me, will feel marginalised or made to feel like we're not proper GPs. But all doctors use our understanding of psychology and sociology to build rapid, trusting and empathetic relationships, perhaps even in a single consultation. I call them speed relationships. This begs new questions. Are these speed relationships less substantive and therefore less effective than the ones that are built up over time? Even if they are, is the concept of a relationship light model a useful addition to our repertoire? The third question is whether remote consultations are a threat to relationship-based care. I don't think they inevitably are, although the evidence I cited earlier does point to problems. But the established evidence, particularly evidence that's 20 plus years old, is not necessarily a predictor of future outcomes. Other kinds of telephone and video consultations that we're conducting now during the COVID era, different from ones in the past, perhaps more substantive, for example. Can we develop remote consulting skills to close the gap between the benefits of face-to-face consultations and remote ones? Can technology be used to encourage relationship-based care? Digital triage, for example, can play a role in ensuring that patients receive continuity of care, as well as receiving the right mode and duration of consultation. My fourth question is whether relationship-based care can be delivered as well in large practices and by multidisciplinary teams as in small practices and by small teams. The answer is yes, but it is more difficult. Relationships need to be actively designed into the new models of general practice. And there are examples of this happening in a thoughtful way, including, for example, shared personal lists and multidisciplinary micro teams. My fifth question is what can we do as a college to raise the profile of relationship-based care and persuade policymakers of its importance? Most GPs, of course, understand the importance of effective relationships, and most patients value them most of the time. But policymakers and NHS leaders can be a challenging group to persuade of the benefits. Increasingly, midwives seem to have persuaded policymakers that continuity for antenatal and intrapartum care is essential and leads to better outcomes. But GPs haven't yet managed to make this case. I think we need to talk about relationships more, highlight its importance using the empirical evidence and case studies that I presented today, and challenge examples of policies and practices which damage the formation of relationships. And I suspect we'll be more effective in getting these messages across if we speak the language of those we're trying to influence. Policymakers are rightly focused on value, the best outcomes for the lowest cost. Research evidence shows that trusting relationships reduce unnecessary prescribing, reduce investigations, and reduce referrals. In contrast, treating presenting problems in a transactional way can be very wasteful. How many of us have seen problems come back again and again because we're not following them up ourselves personally? These are the kind of languages that policymakers want to hear. And finally, my sixth question is how can we support clinicians to practice relationship-based medicine to best effect? Most obviously, of course, we need the time for what Victor Monchuri, one of my heroes, called unhurried consultations. And the college continues to work hard to reduce our workload and increase the time in each consultation. I think we need to be more explicit that utilising the benefits of relationships are a core component of general practice. And this needs to start at an undergraduate level in order to attract those doctors into our specialty who want to practice relationship-based care, who, if you like, are as interested in people as they are in diseases. We need to ramp up teaching and training about relationship-based medicine in the specialist training curriculum, whilst at the same time recognising that some early career doctors may not see the full value of relationships until they've got more consulting experience. In particular, more training and support is required in remote consulting to support all of us to develop our skills in providing relationship-based care. The extent to which consulting face-to-face and remotely requires a different skill set is increasingly recognised, and there are some pointers that help us to focus on important educational areas. For example, we know that patients benefit from preparation for all consultations, and remote ones are no exception. The advantage of digital access using things such as e-consult are that they encourage patients to work through what they want and perhaps how to make the best use of different options when they get to see a doctor or other clinician. So, in summary, relationship-based care is a fundamental feature of effective general practice. And I think that our ability as GPs to deliver it is at risk. And the less opportunity there is to utilise relationships, the less practitioners and patients experience it, the less it will be valued, and the more it will be at risk. So I think there's an urgency in our need to address this challenge. We need to make it clear that there's nothing soft about relationships, and our interest in relationships isn't a yearning for a lost and never to be rediscovered past. Relationship-based care is deliverable, despite the many challenges that we face. I think that our college collectively and all of us individually have a central role in promoting the benefits of relationship-based care. And I really hope that you will want to contribute to this endeavour. Thanks so much for listening. And I'm really happy to take any questions either about what I've been talking about or about any other issues you want to talk about.
Thank you, Martin. That was a great presentation, and I think a topic that not many people actually talk about, really, about the importance of relationship-based medicine and how that's changing in the current climate. So thank you for discussing that important topic. I know from the chat, lots of people have found that topic very useful. So, Amin, have you got any comments from the floor?
Well, firstly, Mike, thank you so much, Prof. Mike. That was really useful. Quite a nice open discussion as well, and something that I think is important for trainees to hear about relationships and how the college sees these really important aspects of primary care. And we've got, as Pooja said, lots and lots of nice comments coming through about the usefulness of that talk. So thank you so much to everybody who has commented and asked questions. We've got quite a few actually. We're just trying to jot them down. Pooja, do you want to kick off with the first one?
Yeah, I think an interesting one, and one that usually comes up again and again, it's around the 10-minute consultation. So someone's put down here, wouldn't it be better to adapt the time allocated to the patient to the needs of the patient rather than being fixated or training us to achieve the impossible in 10-minute consultations?
Yeah. I think that's spot on. I think that's exactly right. And I think we've had some really interesting challenges about the extent to which the exam is based around the 10-minute consultation. The reason that we've done that is because that's the reality of general practice right now. So there's an interesting question about whether we should be trying to change that reality by changing the exam. I don't know. It's an interesting question, but I think the question is spot on. I mean, let me tell you, I've been a GP for 33 years now, and when I started as a partner in general practice straight after my GP training, on a busy day I was seeing about 20 patients on a busy day. Now, I did quite a few home visits, which we tend not to do fewer of now. I was on a 1 in 4, 1 in 5 out of hours rota, but that was usually quite quiet. But 20 patients a day meant that you could deliver high quality care to those patients. Now, in my practice, we see somewhere between 60 and 70 patients. Not all face-to-face, some of them on the telephone. There's no way that you can provide personalised care or relationship-based care in that kind of environment. So I agree entirely that we need to do something about that. The question is what in the current environment? Ideally, what we need is more GPs. It's quite simple, really. How successful we've been at delivering that? Not very, is the answer. We're doing a really, really good job at making general practice more attractive for people at the beginning of their career. The number of people that want to do general practice is going up and up. Our training schemes are almost completely full now, which isn't the case in, say, paediatrics or many other specialties. The number of training places that we're making available is going up and up. We're hoping to have, depending on funding, 4,000 training places this year for general practice. 3 years ago, it was only 3,200, so going up dramatically, and all of those places are being filled. So that's great. The problem is at the other end of careers, we're seeing growing numbers of people working part-time and growing numbers of people, my peer group, for example, retiring early, which is really sad to see. And that's because general practice is a job that seems to require so many compromises at the moment. Now, there is a question about how we redesign general practice before we're able to get a larger number of GPs on board, which, Pooja, I'm very happy to answer, but it's a slightly long answer. So maybe I should stop there and come back to it, unless you want me to describe it now. But I think there's something about the way that we as expert medical generalists use our skills as part of a team, which would help us perhaps to free up space. But I'm happy, if you want me to talk about that, Pooja, I'll have to do so.
Sure. If it's okay, Professor Marshall, we'll move on to a different one because lots of people have got lots of questions coming in.
Please call me Martin, by the way.
Thank you, Martin. So I think there are quite a few questions coming in, and if we have time, then we can certainly come back because you've been gracious to give us a large amount of time for questions. And do you want to ask the next one?
Yeah, Martin, thank you. As you can see, there are lots of trainees from all across the UK on the conference today, and someone's asked the question, how level is the playing field of quality of training from one part of the UK to another, and how is that managed and assessed?
Yeah, so training is a responsibility of the statutory education bodies and the deaneries working to the statutory education bodies. I think by and large, my impression is that the quality of training is reasonably standardized, at least in so much as the training that trainers have to go through and the assessments of their practices is standardized and pretty rigorous. So, I think inevitably you'll always find, one practice that isn't quite as good as another, one trainer that's not quite as good as another, perhaps a trainer that you don't click with as well, for example. But by and large, the standards that the statutory education bodies, Health Education England and Scotland, for example, and their equivalents in the devolved nations set are high standards, and they are national standards. So by and large, they should be the same. If you're having a less than good experience, what you need to do is to go to your local training supervisors, to your statutory education body, and ask them. The actual provision of training is not the college's responsibility. Our responsibility is to set the exam at the end of training, which is why the college doesn't always feel a great place at your stage of your career, because it's kind of it feels like a bit of a stick, the college. It becomes better when you become a GP and then established in it, I guess.
Yeah, great. That's a great answer, Pooja. So in following on from that.
Yes. So somebody's actually asking about the AIT membership, and they're not sure what it offers. So can you point them in the right direction, Martin, where they can actually find more information about how to make the most of their membership?
Yeah, please go on to our website and have a look at what our AIT group is doing specifically. So the AIT group is a really brilliant group. It's quite expanded, actually. So originally it was a committee with a fixed membership for a year, chaired by somebody who'd been elected from within the committee. Now it's much more of an online discussion group. So anybody can be part of that group, anybody can join it. There's lots of opportunity to learn and share ideas together and develop together through that specific group. And then, of course, being an AIT, a member of the college, you have access to everything that the college does. So that'll be CPD resources, that'll be conferences, it'll be webinars, it'll be advancing from the policy lobbying work that we do, the media work that we do. So there's a whole range of assets that the college offers to all of its members, whether you're a trainee or not. And what we're doing as a college is trying to open up a whole range of different groups to our members. So traditionally, general practice is general practice. We've got our own body of knowledge. We've got our own specialty here, and the whole college was focused on that kind of generic body of knowledge. Whereas increasingly, we recognise that people have specific interests within general practice. They might be clinical interests, but they might be health inequalities. They might be sustainability, planetary health. It might be pediatrics, it might be anything. There's a whole range of different areas. And ethics, for example, we've got a great ethics group. What we're trying to do is turn those committees, which were previously fairly tight, into social interest participatory groups that you can join or unjoin depending on what your particular interest is at the time. And there's some really stunning work, particularly going on around health inequalities and around planetary health at the moment, that a lot of our younger colleagues are really getting engaged with and really driving forward. So please do have a look at it all.
Brilliant.
Yeah, really helpful.
Yeah, thank you, Martin. Sorry, just to give you a comment based on your presentation, but the beauty of general practice is you gain time with some consultations and you lose some with others. Surely that's the beauty of being in general practice in the first place. A new presentation of a complex medical complaint would therefore normally take longer than 10 minutes. So I thought it's useful to share a different viewpoint about how somebody's looking at the 10-minute consultation model.
So can I use that as an opportunity, Pooja? We've got a bit of time, haven't we? Let me use that as an opportunity to talk about what general practice might look like, because I fully understand that, and we all do that, don't we? We breathe a sigh of relief when somebody needs a pill check or a blood pressure check, because we know that's going to be a 3 or 4 minute consultation that allow us to catch up or to spend longer with those who need it. And I fully understand that, and I think that model of general practice is still available for those who want it. But what I'm seeing when we don't have enough GPs is that this traditional model of general practice, which is being all things to all people, doing everything, is no longer sustainable. So we have a skill set as expert medical generalists with a significant and intense period of training to become expert generalists. We have a set of value that we bring that I think we need to be more focused on. And it seems to me that if you look at what GPs do really well, we're very good at quick decisions. We're very good at triage, so because we're good at managing uncertainty, good at managing risk. So we're good at that. We're very good at managing complex patients, biopsychosocial complex problems. We're good at that. And I think we're increasingly becoming very good at the kind of community health improvement role of general practice, addressing health inequalities in our communities, building on community assets, using, addressing social determinants, using social interventions. We're really good at that. So those are 3 things that we do really well. Where we're not required is the big bulk of stuff in the middle, which is relatively transactional and can be done pretty much as well by other members of our expanding teams, whether they be nurses, whether they be pharmacists, whether they be physios, physician associates. So whilst, you know, I like the idea of us being all things to all people, I think we need to accept the reality we don't have enough GPs to do that. When the number of GPs is constant or even dropping in places, and the demand is going up, and what we can do, not just demand, actually what we can do is going up and up. So either we get more and more stressed and more contained and more rushed in what we do, or we have to step back and say, okay, so where do we add greatest value? And how do we work as members of an expanded multidisciplinary team to allow us to do things in a high quality measured way, creating time for us? And I have to say that until we get tens of thousands of new doctors, and I don't know when that will be, I'm not sure we have any choice but to be just a little bit more thoughtful about where we add greatest value. Now it's a slightly provocative view. I know some people don't like it, but I'd love to hear what people think about it. I'd love people to give me a better idea as well, if you can.
Yeah, there is views that match those really. Some people comparing the 10-minute consultation time to that of their colleagues who work in secondary care and outpatient clinics, saying, why as GPs do we only get 10 minutes, whether it be a new patient or a patient that is known to us, as opposed to our secondary care colleagues that could get up to 30 minutes. And that certainly does have an impact on the relationship-based care that we're able to provide. That's just a few of the comments coming in comparing primary care to secondary care. So I think there are mixed views from both sides really, Martin, and I suppose that probably reflects what you see on the ground as well. If I could come on to a question that I know is always being asked, it certainly was asked when I was a trainee as well. What are your thoughts of the exam fees?
Yeah, it's expensive, isn't it? It is expensive at a time when, you know, you have so many other commitments in your lives. The commitment that we've made as a college is that we make no surplus, no profit out of exams. So we have to cover our costs. Now, inevitably, you can't do that every single year because the development costs up front for a new exam are expensive. But over a 3 to 5 year period, we make sure that we only charge what is necessary in order to allow us to cover the exam costs. The alternative would be put up the main membership fee of established members so that they're paying for everybody's training, which is a model, but it's not a model that is very attractive to the vast majority of our members. So I think the exam is what it costs. It's a rigorous, high stakes exam. It's one of the best respected of the professional exams in terms of the evidence based underpinning it. So we haven't cut any corners in developing it. So it is expensive, but I think it's necessarily so. One of the big problems for us in comparison with other specialties is whereas at least in the past, becoming slightly more difficult, if you're a physician or a surgeon and you're an examiner, you're given time off by your hospital in order to come and do your examining. Then up to 5 days a year you can spend doing that. As a GP, that's not possible working in a practice, and so we pay our examiners enough to cover a locum fee to cover them, and that ups the cost as well. So I kind of sympathise. I'm sorry, but the costs are what they are, I'm afraid.
As a constant discussion, isn't it, Martin, that will happen, and trainers will ask that question. And one thing that's followed on from that, and one thing I've heard a lot of trainees a little bit upset about, is the Innovate Journal. They really used to enjoy having the journal posted out as hard copy. I've had a question come in saying, what was the reason for going online? Because they're saying, well, online I probably wouldn't look at it as much.
Yeah, Yeah, it's interesting question. I think we, in making that decision, in part, we assume that most, particularly of early career doctors, are accessing stuff online anyway. But I know that isn't always the case. You know, I like having something hard that I can, dare I say, I read when I'm lying in the bath or whatever. You know, I quite like that. But actually, the reason for doing it is trying to get the right balance between access and cost. You probably won't be surprised to hear that our college, like every college and every institution, every charity, we're a charity, is under quite significant financial stress. We lost quite a lot of income as a consequence of the COVID crisis, and we're having to make hard decisions in a range of different areas. So, for example, we've reduced the number of staff that we have in the college. We've reduced the number of officers that we've had. We've just decided not to reappoint one of our officers, which is a real shame because it's such an important role. So we're generally looking at ways of cutting costs. And one of those ways is in the publishing department by putting the journals, including actually, unless you ask for it, the BJGP, largely online. And you know, maybe if people are really uncomfortable with that, maybe we can reverse that decision when our finances are looking better. But right now, it's a necessary cost saving.
Yeah, and I guess that's the challenge that a lot of organisations have had over the last year, haven't they, in terms of
exactly.
the development.
You know, like massively so. I had a meeting recently with the chief exec of Alzheimer's UK. Their income, which is actually a lot of it was charitable income, shops or whatever, dropped by 60%, and they've laid off 70% of their staff. You know, that's the kind of crisis that charities are in. We, as a college and other Royal Colleges, we're in a relatively good position in comparison with the charities that needed shaking tins on high streets.
Yeah, I can imagine. And that kind of leads on nicely to a question about COVID itself, and what were the most challenging parts, both of you as a chair and for the organisation itself going through the pandemic?
Yeah, well, there were lots of challenging tasks, it must be said. And yeah, when I stood for chair, I don't think anyone expected a pandemic to hit us, the biggest crisis that the NHS has seen since we started. So it's been an interesting experience. Where do I start? There are lots of challenges. I guess, you know, the first one was just the big challenge of making sure that the college was in a position to support our members in the crisis, making sure that we were able to provide guidance, we were able to provide support, we were able to provide educational materials, everything that we needed to do in order to support people through a completely unprecedented crisis. And I think if you look at the range of materials that we produced at real pace, often cutting corners in terms of the traditional kind of bureaucracy and governance in the college, we just got on with it. I think we've done a pretty good job there. So there was something there. There was something about the vaccination program, which is interesting. You know, it seems obvious now that general practice was going to be brilliant at the vaccination program, but when we were first asked what should the role of general practice be, and our view was, well, we've got a track record of delivering it. We've got an infrastructure of delivering mass vaccination programs. We've got an infrastructure. We've got a workforce that's there, and we've got the trust of our communities. Therefore, we should play a role despite the workload pressures that we're under. We kind of had our heart in our mouth because we weren't sure whether our members were going to rise to that challenge. What we've seen is they've risen amazingly. Now, 23 million vaccinations given, 75% of those delivered in GP centres. Isn't that incredible? I mean, what an achievement by general practice. So the way that general practice responded has been truly amazing. And then there's been lots of kind of more technical issues in which we've had to make some quite hard decisions. The availability of PPE in the beginning, the delayed second dose, the prioritisation of the vaccine, a whole range of quite complex decisions where we had to make a decision about whether to support the advice that was being given by our colleagues, particularly the CMOs in the 4 countries and JCVI and MHRA, or whether we push back. And our stance throughout has always been that there has to be a good reason for going against CMO advice. And that's because we're in a crisis. You know, we're not saying the CMO knows everything, is all knowing, and will always make the right decisions. Although I have to say that I think the 4 CMOs have done a really good job. Most of the time, the evidence has proved their punch to be correct, which is great. But at a time of crisis, behaving collectively as a medical profession, we thought was a really important principle. And that's one that we stuck to. That doesn't mean that we haven't criticised government, because we have done. There's a lot of things that this government has done really badly. There are other things like the vaccination program that I think is done really well, and let's give due credit when it's due. But overall, I think there's always a degree of anxiety in our minds as a leadership group when we make a decision based on things where there isn't much evidence, like the delayed second dose, where we just think intuitively it's probably the right thing, so let's support it. And then you keep your fingers crossed and wait for the evidence to emerge. And unfortunately, it has emerged, and it's largely supported that. So there's those technical things. And then finally, just a question of keeping morale going. And it's the same in the college as it is in our individual practices. When people are under stress, they're working hard, they're worn out, there feels like there's no end to it. They've got all the family problems, lockdown, everything else going on as well. Maintaining morale, maintaining spirit, keeping people happy, keeping people talking to each other, keeping people even decent sometimes, actually, because there's a lot of anger out there, is a really big challenge for all leaders, I think, and it's been the same for all of us. We've got great people with strong values, strong principles, but everybody's been under stress, and one of my jobs is to keep calm when people around me are sometimes losing their heads. Done my best. Sometimes I've lost it too, but most of the time I've tried to be calm.
Rita, there's a last couple, I think, coming in, some interesting ones.
Thank you for being so honest, Martin. And that's always a sign of a great leader, staying calm when everything around you is chaotic. So I suppose a question that has come in recurrently, and you may not know the answer to this, but it is the million-dollar question at the moment for trainees in the earlier years. Is the RCA here to stay? And do you have any updates about the RCA?
Yeah, it's a really key question, isn't it? So everyone will know why we changed from the CSA to the RCA in a very short period of time, having to develop a new exam that would usually take 2 or 3 years in 2 months. So again, an amazing achievement by the exams team led by Michael Mulholland, one of our vice chairs. So we had to do that because of the undesirability of travelling into London and doing things face to face. It's gone down really well with some people and really badly with others, and I understand the reasons for that. It was always meant to be a temporary measure, so it wasn't designed to be permanent, and we were clear about that to the GMC, which is the regulatory body for the exam, and the GMC were clear about that to us as well. So the question is, how long does it go on for? And I think it'll probably go on until probably middle or late next year would be my guess. So because we just don't know where the crisis is going at the moment. There's no point in designing something that we don't know, what the future is going to look like. But in the meantime, what we're doing is looking at what the new exam might look like. We've just had some provisional plans signed off by our trustee board and by our council, which will allow us to develop groups of people together, including a very loud trainee's voice, in order to look at the nature of the exam. And our thinking at the moment is it will probably be some kind of hybrid exam. So there will be a return to some case studies using the CSA method, but remotely, not face to face. The idea of travelling into London from Northern Ireland or Scotland is just no longer viable. So there will be a CSA base because that allows you to standardise assessments. But there'll also be an RCA basis as well. The advantage of that being it's unstandardized, but it's real life. So I think probably a combination of the two. Now, I don't know how that will play out as the exams group works. There's a lot of moving parts. There's a lot of players here. The trainee voice is fundamentally important to it. That's why you need to get involved in the AIT group right now, so that you can influence it through that group. Who knows where we'll end up, but I think we've got a good process for determining it, and we'll be sharing, our learning and our thinking along the way.
Super challenging to develop super challenging to develop a new exam in a very short period of time, as you've mentioned. And we've had a couple of trainees who are coming to the end of training in August, and they're wondering about the last RCA sitting being May this year, and they're wondering if there's likely to be another one in the summer. So that's maybe something that I don't know if you have the answer to, Martin, but that would be helpful for ST3s finishing in August. And then one other question before we leave the exams is about the AKT, and a very simple question is coming saying, why is it so tough? I said, why is the AKT so tough?
I don't know the answer to that question, I'm afraid. It's the knowledge that we need for general practice, and general practice is a tough specialty. So maybe it's slightly trite, but that's probably the answer. I'm afraid I don't know the answer to to the RCA, but if Aman or Buja, if you just email me, I'll find out and let you know the answer, and then you can tell everybody.
Thank you. Just a few comments just before we wrap up, because you wanted to get a feel of what people were thinking around the points that you raised. Someone, once again, a common opinion from what I see as well. So does that mean if other allied health professionals take up some of the easy consultations, that leaves GPs with more complex consultations and therefore less chances to catch up? That's one comment that somebody's made. Other things, someone's written, from a patient perspective, as a patient, I haven't seen my name GP for at all during the 2 years. I see a different GP every time. How can we as a profession avoid this? And how can we get the patient seen by the name GP most of the time so that we can build a relationship? Once again, that's an ongoing discussion. Very useful. Thank you, Professor Marshall, to be reminded to get the basics right. Continuity of care is central. It makes work for GPs easier and more efficient, as I can sometimes bring in past knowledge of patients to help deal with a current problem. We also need to strengthen our relationships with secondary care colleagues, especially in the palliative care setting. So yes, a wide range of views really. We do have a GP PCN pharmacist who said, I'm finding patients have increased degree of access to GPs for acute conditions, therefore enabling clinical pharmacists to manage long-term conditions. So as you can see, there's a wide range of views, and I appreciate your honesty, Martin. It's not easy keeping the floor open and saying that you're happy to answer anything and everything. So I think on behalf of the audience, I must say thank you. But is there anything that you want to finish off with based on the views that you've heard?
No, just really to say that we've got a specialty that we should rightly be very proud of. You know, we do have the most important job in medicine. I don't think there's any doubt about that whatsoever. We know absolutely that the NHS would collapse if we weren't able to do our job properly. It is a tough job at the moment. I don't think anyone should pretend otherwise. It's a really tough job, tougher than it used to be. And that's why we all need to engage in college and political activity, college and BMA activity, in order to make it a better job. It seems to me that's our responsibility as professionals. And when I think inevitably there's a tendency for us to look for answers, assuming that somebody knows the answers. And at a time of significant change, that isn't usually the case. And what I've tried to express, I hope it's come across, is the inevitable uncertainty in so many of the complex issues that we're trying to deal with here. And I'm not pretending there's a simple answer. I'm not pretending I've got the answer. What I am pretending is together we can develop the answer. And that's what we need to do. And that's why I really urge people to really engage with the college, get involved. I got involved in the college, not because I like institutions. I don't like it. Actually, I don't like institutions very much. What I really like is being with a group of people who share my values, but think completely differently, have different views. And that to me is what the college has always been. I joined in 1987. Ever since then, it's been my main place where I've managed to mix with exciting, bright, engaged, committed people, and that's what's given me the energy throughout my career. And so, please, let's hope you're able to do that as well.
Brilliant. Thank you so much, Martin. It's been really, really helpful, and hopefully we've covered quite a lot of ground there actually, and things that trainees have on their minds, and things that maybe they'll have in their minds in the years to come when they qualify as GPs. So thank you so much for your time. Pooja, any last words?
No, thank you, Martin. It's been really useful. In terms of if there are any further questions, is it okay to just put them through to you via email if there is a general theme?
Yeah, of course, please do. Yeah, please do. No, it'd be a pleasure. And good luck to everybody. I hope you have a great day.